Hello, everyone. The Coordinating Center for the National Drug Early Warning System and the National Institute on Drug Abuse welcomes you to our second NDEWS Presents monthly webinar. Our NDEWS PI is Dr. Eric Wish, and our NIDA project scientist is Moira O'Brien. My name is Erin Artigiani, and Marwa Al-Nasir and I will be the facilitators for this webinar. We are a part of the Coordinating Center team for NDEWS, which is supported by funding from NIDA. For those who are interested, you can find detailed information about NDEWS and invitations to future webinars and recordings of our prior webinars on our website at www.ndews.org. That's www.ndews.org. You will also find instructions for how to join our NDEWS network and participate in our ongoing discussions with more than 1,000 experts and concerned citizens from across the U.S. and more than 20 other countries. Our NDEWS Presents monthly webinars are a new feature that we developed to work with leading substance abuse experts to explore emerging drugs and timely drug-related topics. This month, we will be discussing the recent increases in opioid-related overdoses and the relationship between prescription opioid misuse and heroin abuse. We are very fortunate to have not one but two great presenters this afternoon. First, we will have Dr. Wilson Compton, Deputy Director of NIDA, who will speak about responding to the opioid morbidity and mortality crisis. And then we will have Dr. Daniel Ciccarone, Professor of Family and Community Medicine at the University of California, San Francisco, who will speak about emerging patterns and new types of heroin in U.S. communities. This webinar will be approximately 2 hours long, and we encourage questions during and after the presentations. Please post your questions in the Q&A box. We will have two brief Q&A sessions during the webinar to respond to them. During the second Q&A section, you may want to minimize your video panel to avoid discomfort from the continuously switching video from speaker to speaker, since there will be three of us. Our speakers, Marwa and I, will do the best to get to all of your questions, and we will also post a Q&A with responses to all of your questions and comments submitted to ndews.org after the webinar, along with a full recording of the webinar and copies of the slides for each of our presentations. So thank you again for joining us. We hope you enjoyed the webinar, and I will turn things over now to you, Dr. Compton.
Well, thank you, Erin. It's certainly a pleasure to be with you today and to be able to discuss with you the issues of how prescription opioid misuse and abuse and the epidemic that we've seen in terms of the increases in both general medical use of prescription opioids, but then the problems related to that issue, particularly the mortality that has been increasing so much in this country in the last 15 years. Now, let me begin sharing my screen so I can make sure that I have the slides for you. And to begin with, I have some disclosures. I have long-term stock equities that I don't think have any bearing on today's talk, but I always highlight these for you. My goal today will be to discuss with you how we respond to the opioid morbidity and mortality crisis. So I've had the pleasure of working across the Department of Health and Human Services and really all across the federal government to help develop our response. Now, I'd like to say that we've been successful in responding to this. But as you'll see in the data, that we still have a long way to go. And so that's why sessions like today's webinar are so important to help galvanize the best thinking that we can pull together to understand and to respond to this ongoing public health crisis in our country. Now, I've had the pleasure of working on a number of activities related to the opioid drug abuse area, but in particular, I'm going to highlight for you two papers that we've written recently. One focused in the Journal of the American Medical Association on the trends in non-medical opioid use. And I'll share with you some of the information from that because it helps uncover and explain, I believe, some of the discrepancies in the surveillance data compared to the mortality data and the consequences of drug use. So we'll talk about that. And then more recently, what inspired me being invited to do this seminar with you all was a publication in the New England Journal of Medicine that highlighted a summary of how non-medical prescription opioid use and heroin are related, and the complexities of this synergistic relationship between these different aspects of the opioid crisis in our country. Now, what's been driving all of this, of course, has been the attention because of the market increases in the overdose deaths. What we've seen over the last 15 years is more than a quadrupling in the overall opioid deaths. That's the solid blue line at the top. The dashed line represents the prescription opioid deaths. And indeed, most of the increases up through around 2010 in the opioid deaths were due to the increases in the prescription opioid-related deaths. But in the last 5 years, we've seen a dramatic and market upswing in heroin. I will point out, and I think Dan will highlight this for you in the next presentation, that these increases in heroin started before 2010, but they really accelerated during the last 5 years, so that there's been something like a quadrupling of the heroin-related deaths just in the last 5 years. The most recent data remind us that there are some 47,000 persons dying from a drug overdose related to the opioids or other drugs in this country. That was in 2014. The largest single group, of course, being the opioids and the prescription opioids within that. Now, how do we understand that number of deaths of 47,000? That's in a single year, and that's nearly the same number of people that were killed during the entire Vietnam War. It's about the equivalent of, if these were plane crashes, it would be about the equivalent of 2 fully loaded 747s crashing every week in the United States. So I always struggle with how to explain these very large numbers, and I look for opportunities to convey that to the public in terms of these analogies. But it is, in any stretch of the imagination, a startlingly large number related to drug abuse and drug addiction. Now, in our paper in the Journal of the American Medical Association, we were really addressing a bit of a conundrum. In that previous slide, I just showed you the skyrocketing rates of opioid mortality, the overdose mortality increasing dramatically related to prescription drugs and heroin. Well, this is data coming out of the National Survey on Drug Use and Health over the last 11 years, so 2003 through 2014. And what we see is that when you look at the rates of any non-medical use of prescription-type opioids, we see a level, or if anything, a decreasing. The trend is significant, but it's a modest decline over the last decade. Well, how do we understand that? Well, let's look at that by disentangling that into 3 different groups. First, we look at those who use these prescription-type opioids non-medically, but do so at a relatively infrequent basis. So these are those who use fewer than 100 days out of the year. So they could use as frequently as once a week, but not more than about once a week. And they don't have any evidence, they don't report the symptoms of a disorder related to the non-medical use of opioids. So no DSM-4 abuse or dependence related to them. And indeed, those numbers have been trending down. Simultaneously, we've seen an increase, and this is about a 40 or 50% increase over that decade, in those who have abuse or dependence related to the non-medical use of prescription opioids. And indeed, those who use the opioids frequently had a market increase as well. So this is at least somewhat reassuring that even the public health surveillance data have some consistency when those who are obviously most at risk of having the morbidity and mortality associated with their non-medical use of opioids, those who are frequent users or those who have abuse or dependence, that those numbers have been increasing over the past decade. So to that extent, the public health surveillance data are consistent with the increases in mortality. They're also consistent with the treatment data that we've seen. So we've seen about a tripling, a doubling to a tripling of the number of persons entering specialty treatment related to the prescription opioid medications. More recently, in 2015, we saw an outbreak of HIV in a remote rural part of Indiana. This is Scott County, Indiana, that's in south central Indiana. It's actually about an hour north of Louisville, Kentucky. So it's in much closer to Louisville than it is Indianapolis. And this outbreak was associated with a dense social network that was also built around families who had intergenerational use of particularly prescription opioids. And oxymorphone was the major drug that was used in that drug-using network of injection drug users. The outbreak of HIV is quite startling in that the overall rates in a county with a population of about 4,200, there are now 185 cases. The publication in Morbidity and Mortality Weekly was from a slightly earlier subset of 162 cases, but the overall rate now is about 4% of the overall population are HIV infected. That's a startlingly high prevalence rate of HIV in this community. And one of the things that was noted when they started doing the epidemiology, surveillance, and outbreak investigation was that a large number of the individuals had pre-existing hepatitis C. And indeed, that may be a warning sign for an ensuing potential issue with HIV, and it certainly is a very serious, potentially fatal condition on its own. So hepatitis C has been identified in many, many communities across the country because of its association with injection drug use. And indeed, these are driven by opioid use, whether it's heroin use or the prescription opioids, depending on the community details. But this relationship of the opioids to infectious disease has been remarkable and, of course, very concerning. So we've seen the direct mortality in terms of the overdose rates. We've seen increasing treatment. We see problems related to infectious disease, hepatitis C, and most recently in 2015, the HIV outbreak. We've also seen increasing neonatal abstinence syndrome, which are hitting some of the same regions that have been identified as the hotspots for heroin and or prescription opioid type issues. So we see a variety of problems related, underlying this, to the high rates of non-medical use of prescription opioids and the subsequent issues around heroin. Now, what's been driving this have been the high levels of opioid prescriptions. So what we've seen over the period from 91 to 2013 was about a tripling of opioid prescriptions. Interestingly, there's been a little bit of a leveling off in the last few years, and yet this is when the heroin epidemic has accelerated, at least in terms of the overdose deaths and somewhat in terms of the evidence for increasing number of people using heroin. But the upstream driver seems to be this exposure to opioids. Now, interestingly, it's not a direct exposure necessarily, it can be indirect. That's a bit of a conundrum to practitioners, because it means that clinicians need to be thinking about not just the prescription and how that will be used by the patient to whom it's written, but it also extends to those in their social environment. So their family, their friends, their neighbors, those that they may share those prescriptions with. So particularly unused medications seem to be becoming an environmental issue in terms of this spread of non-medical use of prescription opioids. The number of opioid tablets dispensed in our country in the most recent data in 2013 and 14, nearly 16 billion tablets dispensed, means that there's an awful lot of these opioids potentially available for diversion and misuse and non-medical use. What we have seen is a strong correlation in terms of the overall opioid sales. That's what we see in the blue line that's on top, and it's strongly correlated with the increases in opioid-related deaths and the opioid treatment admissions from 99 through 2010 or 11 in this data set, as highlighted particularly by the CDC. And this is some of our evidence of the strong relationship of the opioid availability and the consequences, whether that's treatment admissions or deaths related to the opioids. There's a tremendous overlap of benzodiazepines, so other sedating agents that may accentuate the effects of opioids. And indeed, we see that there's been an increase in the relationship of benzodiazepines to the opioids, both in terms of their relationship to overdose deaths and emergency department admissions. This is a very nice paper by Chris Jones and colleagues that showed that among those who were either seen in the emergency department, that's here, or had deceased, and their deaths were related to their opioids, that an increasing proportion were affected simultaneously by benzodiazepines. Now let's look at this the other way. As a clinician, I was trained that benzodiazepines are relatively safe for overdose, that they rarely by themselves produce an overdose, and indeed this data might suggest that. Because what you do see that in the deaths that are associated with benzodiazepines, the relationship to opioids is almost 100%. So it's between 70 and now over 80% of cases in recent years have benzodiazepines on board in addition to their opioids. And we see that increasing relationship in non-fatal overdoses. So in the emergency department, visits related to benzodiazepines also frequently are related to opioids. So that's the other key message. It's while we're concerned about the opioids, it's not just the opioids. Indirectly, by creating a situation where there are millions and millions of people with problematic use of the prescription opioids and tremendous availability of heroin in communities all across the country, we've seen a marked increase in heroin overdose deaths in the last few years. That's what we see on the right, a skyrocketing rate of heroin overdose deaths. But we also see an increase in heroin use coming from the National Survey on Drug Use and Health. So this is almost certainly an underestimate. It doesn't include incarcerated individuals, those in institutions, and homeless individuals where the rates of heroin use are certainly higher than in household populations. And yet we see nearly 1 million persons reporting past year use of heroin and over 400,000 reporting current or past month use of heroin in 2014. These increases in heroin have been ubiquitous around the country. They've been in all the different regions, although I would point out that the Northeast and Midwest have been particularly hard hit with the increases. We see that there have been increases in the major demographic groups, so both non-Hispanic whites, non-Hispanic blacks, and Hispanics, but the increases have been particularly acute for non-Hispanic youngish, so 18 to 44-year-old non-Hispanic whites, or for the more middle-aged, 45 to 64-year-old non-Hispanic whites. And we'll come back to this in a moment, because it's actually showing, overdoses are showing an impact in overall survival for this group. Ted Ciccarone and colleagues have been reminding us that there's been a real shift. This is part of why we think that the prescription opioids are related to heroin, that most people now admitted for treatment of heroin addiction, most of them, their first exposure to an opioid was prescription opioids. Well, one way to think about this is if you went back 30 or 40 to 50 years now, in the 70s or 60s, those starting opioids at that time, their first opioid exposure would have been heroin. It doesn't mean that they didn't use prescription opioids, but when they first began using opioids, it would have been heroin back then. Starting in the 1990s and particularly the 2000s, the first opioid exposure was prescription opioids. And while there can be overlap among these, because once somebody started on that pathway, they very readily will use whatever opioid is available to them, whether that's a prescription drug or street heroin. But it's been quite a shift that the first opioid exposure tends to be the prescription drugs now. Now, that's sort of the bottom line, that most heroin users report previous non-medical use of prescription opioids. But there's another way to look at this. Only a small portion of those non-medical users progress to heroin. Now, so how do we explain the high number of heroin users? Well, they're still relatively low numbers compared to the non-medical users of the prescription type opioids. And only a small portion of those non-medical users progress to heroin. Now, to me, this is an example of even a modest proportion, whether it's 4% or 7%, depending on whose study you're using, whether it's household survey data or a cohort study of non-medical opioid users. But a modest percentage of a very large number of individuals still adds up to an awful lot of people who have progressed and switch to heroin. Another key factor in driving the transition to heroin have been market forces. And so what we've seen that over the last 15 years, we've seen a much lower price of heroin in street markets. Now, to me, this sort of begs the question, well, why didn't we see the increases in heroin starting in the year 2000? I think that's part of the reason why this remains somewhat of a puzzle, and I look forward to having some discussion with you all about what explains the more recent upsurge in heroin use when the market has been relatively stable at cheap and plentiful and available heroin in so many parts of our country for the last number of years. There are some increasing data to suggest that there's been a shift from abuse of the prescription pain relievers to heroin. Ted Ciccarone colleagues showed that when OxyContin, the reformulation, came in, there was a downward trend in OxyContin abuse. Now, it's interesting that the downward trend in OxyContin abuse continues for many quarters, and yet the heroin increases seem to level off at some point. But certainly there is a relationship, particularly for those that may use both prescription opioids and heroin. If their prescription opioid can no longer be ground up and injected, and they're an injection drug user, then are resorting back to heroin or some of the other prescription type opioids is of course going to be the reaction. Now, I've mentioned to you that fentanyl has added a new wrinkle to this issue. It is a particularly potent opioid. It's 80 to 100 times more potent than morphine, 25 to 40 times more potent than heroin. It has a very rapid onset and a short duration of effects. One of the issues is that, does that mean that it's coming from prescription opioids? Is this like the other prescription opioids that are diverted from medical use, at least in some way? The answer would be no. Most of the overdoses are from non-pharmaceutical fentanyl, so they're from illicit manufacture. But I want to point out to you that those mortality statistics, where we saw the market increase in 2013 and 14 for the prescription type opioids, and the market increase in heroin deaths, may be related to fentanyl. If fentanyl is the drug detected and reported on a death certificate, that will be coded by the National Center for Health Statistics among the analgesic type opioid deaths. So this is a particular problem because the interventions may be very different. On the one hand, we're talking about agents that originate from a pharmacy, originate from a prescription, or somehow come from the medical system, at least it's some part of their background. And yet the fentanyl is much more like heroin in terms of its production and distribution. So I do suggest that there may be misclassifications, and thinking through how we can interpret the data will be very important. Some of the reasons we know that there are misclassifications and we think about this bias is where we see the increasing prescription opioid deaths just in the last year have been particularly in the areas hardest hit by fentanyl. So the fentanyl reports are particularly out of New England and the north central states, a little bit out of Florida. This is not our first epidemic with fentanyl. I think it was 2006 when there was another major outbreak with a horrendous number of deaths in Chicago, Philadelphia, and a few other locations. But this recent epidemic is intermingled with heroin and other prescription opioids and has been very difficult to disentangle, but certainly represents a particularly devastating issue because of the high potency and then sometimes the difficulty of reversing an overdose with fentanyl because of the tremendous opioid burden. Now, I suggested to you that this may have had broad population impacts. This is a fascinating study coming out of Ann Case and Angus Deaton's lab at Princeton. Angus Deaton is a Nobel Prize-winning economist at Princeton. And he's been looking at the demographics related to health. And what he and his wife Ann Case detected is that unlike all the other Western European countries, for non-Hispanic whites in the US of middle age, 45 to 54, and actually this also extends to younger age groups as well, that for the first time in the last about 100 years, we see a reduction in longevity, so an increase in the number of deaths for this group. And that's different from all the other countries that have had a continued improvement in lifespan. It's also different than an improvement in lifespan for most other groups in the US. Now, what explains this? What explains it are increases related to drug overdose, alcohol, and suicide. So a tremendous focus on behavioral health issues. So to me, this suggests that the overdose epidemic is not an isolated issue, but is having major population impacts that are now measurable in broad demographic factors. So if you weren't concerned before, this is an additional reason to pay attention to this epidemic of deaths. So why do people abuse the opioids? Well, the brain does not distinguish between prescription type opioids and street opioids. So in head-to-head comparisons in laboratory studies, even experienced drug users frequently can't tell the difference, and the brain responds generally to these type of drugs based on their ability to stimulate the mu opioid receptors in the brain. Most of it's related to at least the initial intoxication and liking of these drugs is related to an increase in dopamine transmission in the central reward structures. Now, I'm not going to go into this in detail, but it's important to remind us that these are common pharmaceutical agents, the prescription types and heroin, and they really don't differ when it comes to their central nervous system impacts, not much. The social factors do explain some of the differences, and I think that helps us understand why it is relatively rare to see people transitioning from prescription opioids to heroin. Despite this sort of being the public expectation that everyone using these prescription opioids is going to inevitably transition, it turns out that social factors help explain the lack of transition and give us ways that we might intervene in multiple parts of the trajectory. I'm also going to highlight for you a general notion that we see the expression of addiction as being due to both innate biological factors. So what do the drugs do to the brain? How much do people like the drugs? Not everyone does. Some people take opioids and they find it extraordinarily unpleasant. Others find it extremely pleasant and want to repeat it over and over. But it's both that the innate biology in combination with environmental factors. And the environment includes things like neighborhood factors, family factors, even laws and regulations are part of the environment and can influence the expression of addiction. We'll come back to this a little bit because this is where we have the opportunity to intervene, will be in the environmental factors. I really can't change the biology, but I do have a lot of options to change the environment to reduce the onset, that's prevention, or to improve the outcomes by improving treatment and reducing relapse. Now, we're fortunate that our new, or relatively new, Secretary of Health and Human Services, Sylvia Burwell, is from West Virginia. When she first came into office, now it's been nearly 2 years, one of her first actions was to convene a small group to tell her what the department was doing to address the opioid epidemic in the United States. And she asked all of us to put our heads together and work with her to develop some priority areas that we could really focus on to help turn this epidemic around. There are 3 priority areas. The first relates to prevention. If we think the upstream driver of this epidemic are the prescriptions, then we better focus on prescribing practices, both to prevent opioid use and non-medical opioid use and overdose. We want to focus on reversing the overdose mortality by expanded access to naloxone. So a potent opioid antagonist is certainly the typical medical treatment when you come to an emergency department with an overdose. If you're blue and not breathing, the first thing they do is give you naloxone to see if they can reverse it. If it's another cause, it's not going to have any impact, but can be very effective if the cause is an overdose. So use of these agents in field settings, that means on the street, by families, by first responders, whether that's emergency medical personnel or police officers, is a key component of this strategy. And finally, a key driver of this is the opioid addiction. We need to be focusing on improving outcomes by getting more people into effective treatment. And effective treatment typically means medication-assisted treatment. So those are the three major priorities. Of course, there are other practices as well, but that's the main priorities. Now, there's some really interesting data coming out of SAMHSA. This is the National Survey on Drug Use and Health, that I think adds another level of complexity to the issue around prescriptions and prescribing patterns. I kind of had this idea that it was me and my colleagues writing a prescription to a patient who then personally misused them that was at the heart of this epidemic. If you'd asked me 10 years ago, I would have thought that was the major pathway. But it turns out that that's not so true. When you ask people who non-medically use the prescription opioids where they got their pill, where they got their last pill, only a few of them, well, a few of them are doctor shoppers going to more than one doctor. About a fifth of them report they get it from their own single doctor. Most of them get it from friends or relatives, either free, so it was a gift or given to them by their friends or relatives, or they bought or stole it from their friends or relatives. But indeed, friends and family represent about 70% of the sources, at least for the majority of the non-medical opioid users. Where'd that friend and family member get it? For the most part, they're getting it from single physicians. So these are not doctor shoppers reselling their prescription. It's not pill mills. It's going to typically family physicians and others, or having leftover medications after an injury or a medical procedure, and then sharing them with friends and family, either intentionally or unintentionally fueling this epidemic of non-medical use. That's what I say when it provides an added layer of complexity, because it's not the direct prescription, but suddenly we need to get physicians to be paying attention to not just to whom they're writing the prescription, but the potential for that prescription to then be diverted and to be misused by others. Who's writing these prescriptions? Well, the largest proportion are by primary care physicians. While they're not nearly as many pain medicine specialists, of course they write a disproportionate number of them. Surgeons, dentists are another place where we need to be paying attention. A significant portion of the prescriptions for opioids in this country are written by dentists, and nurse practitioners and physician's assistants are another part of the issue. So in order to reduce at least some of the most extreme cases, there needs to be information about what prescriptions patients are getting. This way, there can be an opportunity for identifying somebody with drug-seeking or drug behaviors indicative of drug addiction, where they might be referred for treatment. Now, that's an idealistic point of view. And I do think that part of the goal in all of these interventions is how do we link people that suggest that they need treatment for their addiction? How do we link them with effective care? But making sure that information about what prescriptions our patients are getting is available is part of these things called prescription drug monitoring programs that in an ideal setting are linked to an electronic health record and provide immediate access to information about prescriptions, typical part of medical history. Now, the next issue when it comes to guiding prescriptions and changing them might be relate to prescription guidelines. Now, in a review of this background that the CDC, SAMHSA, and NIDA did a few years ago, it was revealed that there were not that many guidelines for how to write prescriptions for opioids. They were somewhat outdated, and they certainly were not written in a conflict-free basis. That means they were frequently funded, either directly or indirectly, by the pharmaceutical industry's support. So the solution has been for CDC to develop and just publish, 2 weeks ago tomorrow, opioid prescribing guidelines. These are for patients getting opioids generally for chronic pain. There's a little bit of information about it, prescriptions for acute pain, so that would be you're seen in an emergency department or post-surgery injury type prescriptions or after dental pain. The main recommendation there is to limit the prescriptions to a small number of days. And there's much less information about how to, what the guidelines should be for acute care, but it's quite clear that there's overprescription in the acute care as well as in the chronic care as well. Chronic care as well. If you have any questions about these, I'll be happy to answer them, but this represents a milestone. It was not an easy guideline to see released. We're very pleased that it's been released just now. So that's number one. When we look at the prevention, as highlighted in terms of prescription issues, we think about the guidelines, we think about use of prescription drug monitoring programs as ways to change some of the prescribing patterns. But when it comes to easier access to naloxone, many have been focusing on greater access to naloxone through community distribution. NIDA has played its role by helping work with, in this case, Adapt Pharma, on the release of a nasal formulation of naloxone. This made sure that the nasal sprayer, which delivers a very small amount of fluid, produces the same dose of naloxone as achieved with an injection form. And that was just approved a few months ago and is just entering the market now. So we're hopeful that this will allow easier access and wider spread distribution of naloxone to patients and the public who needs it. Now, when it comes to medication for opioid addiction, we think in three major categories, and they all relate to whether they act on the opioid receptors. So the mu opioid receptor is responsible for the majority of the pain relieving, the intoxicating, and indeed the sleep-inducing or overdose-inducing aspects of opioid actions. So the mu opioid receptor, it's one of several receptors for opioids, but is the one that's most relevant to the potential negative outcomes, and indeed for treatment. Heroin, oxycodone, and others are potent opioid agonists, so they act at the mu opioid receptor. The main treatments fall into three categories. The full agonist, that means it's fully active at the opioid receptor, so if it binds to the receptor, you see full activity would be methadone. So that's a generally a long-acting replacement. The goal behind methadone is, again, to produce tolerance in individuals that take it. So they take enough of it that if they do slip and relapse and end up using either their prescription opioid or heroin, they will not achieve the intoxication or high that they're looking for. So there's no reward, there's no encouragement to continue that behavior, and they will find it easier to remain in recovery. Buprenorphine has a different method of action, and it's a partial agonist. So it doesn't have as much of an opioid effect. In fact, if somebody's actively intoxicated with opioids and you add buprenorphine, you can put them in withdrawal. On the other hand, if they're in withdrawal and you add buprenorphine, you will relieve their withdrawal symptoms, they'll be more comfortable. So that's what I mean when I say buprenorphine is a partial agonist. It's kind of like a key in a lock and the door only opens halfway. You can't get through as much, but it's still an open door. The effects are similar to methadone in terms of inducing tolerance. And so if somebody does relapse to heroin or other opioids, they don't get the intoxication they're looking for, and they are likely to change their behavior accordingly. Now, the third major medication would be a blocking agent, a long-acting blocking agent like naltrexone. You'll notice that the name naltrexone is very similar to naloxone. That's because chemically they're closely related. The difference is naltrexone can be active when taken orally, so it isn't degraded by the liver, much like naloxone is. As well, there's a long-acting injectable version. The trade name is Vivitrol. This can be given in about once a month injections and is a potent antagonist. So again, when this is on board and somebody were to use heroin or other opioids, they would have no opioid effect at all, at least during those first few weeks. Like any other medication, it's only effective if people are taking it. So compliance and adherence to treatment is a key factor. Participation in other parts of treatment, this is a starting point to help people turn their lives around, but wouldn't be the only way we approach it. Indeed, what we've seen in some public health data coming out of Baltimore is that when they expanded access to methadone, and particularly as they added buprenorphine treatment in that center of the opioid epidemic, they saw a marked reduction in heroin overdose tests. So this is some example from population studies showing an impact of these treatments in real-world settings. I'm going to go through the rest fairly quickly. We've also seen that we can improve the treatment during pregnancy, so that opioid addicts during pregnancy treated with buprenorphine may do better. So we see that there's an opportunity for treatment in all stages of the epidemic and in all stages of use. So I'll focus a little bit on how can research help, focus on a number of key areas. When we think about prevention, there was a very important study. I say 2013 here, that's incorrect. It just came out in 2016, so it just came out a couple of months ago, that reminded us that medical use of a prescription opioid by high school seniors was associated with an increased risk of non-medical use 5 years later. So I think this reminds us that medical use may not be so innocent. So that particularly for those who were low-risk drug abusers, didn't have the other main risk factors, that medical use was a risk factor for later misuse. We also know from long-term outcomes of universal prevention interventions that if we do a good job of supporting families in providing a loving, nurturing environment for their teens and in supervising their teens effectively, they are much less likely to use opioids, just like they're less likely to use other drugs. That these universal sort of protective shield approach to effective evidence-based prevention for middle school students and young teenagers can have a long-lasting effect. I think that's a remarkable and often overlooked aspect of drug prevention that reminds us that drug addiction and drug abuse is a combination of biological and environmental factors. And by manipulating the family environment and the social environment, we can improve the outcomes long-term. NIDA is focusing on less abusable medications. This will, of course, not address the direct misuse of an oral tablet, but it can reduce its ability to be ground up and injected. We're also working on non-opioid painkillers, and we're working on non-medication treatments for pain. For instance, brain stimulation. That's not an opioid. And so if we could use magnetic stimulation to help people function better who suffer from serious pain, that really might reduce our over-reliance on opioids with the iatrogenic aspects of the prescription opioid problem related to the availability of those opioids. We've been working on new medications. There's a buprenorphine implant that is under review by the FDA right now. A series of studies suggest that these implants can have an impact for about 6 months, producing about the same dose of buprenorphine as sublingual, but with the added advantage that it's an injection, a kind of like the Norplant hormone injections for birth control. So it's underneath the skin as a slow release formulation that only has to be done every few months. Particularly for patients in rural, remote areas, this might be a real game changer. We're working on some longer term solutions, even vaccines. Now this is still in the area of highly speculative and a research approach, but the idea is that for a drug to have its impact, it has to leave the circulatory system and get into the brain. Vaccines produce antibodies that bind to the drugs of abuse and keep them in the circulation. They don't cross into the brain, so they don't readily cross the blood-brain barrier. And so you'd be less likely to get intoxicated or high if you were to use a drug. This is a promising approach that's under investigation now, but we're not ready to release it at the present time. Now, the final issue I'm going to talk about is the lack of uptake of medication-assisted treatment. This is within drug treatment programs where, among programs surveyed, very few offer methadone or buprenorphine, and even among patients who should qualify for methadone or buprenorphine, only a minority were actually being offered that medication. So the bottom line is very few are treated. We've seen an opportunity for treatment in criminal justice settings. For instance, the extended release naltrexone, the naltrexone injection, seems to produce, this is from preliminary data presented last year at CPDD, but shows less relapse, greater abstinence, and less and greater lack of drugs on drug testing. Interestingly, these same researchers, Josh Lee and colleagues, have a suggestion that those that got the extended release naltrexone were much less likely to have any overdose. So the only overdoses they saw were in those that were in the control group. So it may be that naltrexone, particularly for these criminal justice involved individuals who are at such high risk of overdose when they're first released from prison may be a life-saving intervention. Now, another way to approach the lack of implementation has been in emergency departments. Gail D'Onofrio and colleagues recognized that the emergency department was kind of the de facto primary care setting for so many of their opioid-addicted patients. And realizing that they were not having success in making referrals to treatment, even though they work in New Haven, which has pretty good access to drug treatment, they weren't getting their patients to attend treatment. So they said, well, let's start buprenorphine in the emergency room. Let's treat our patients with the understanding that we will serve as their primary care physicians, at least temporarily. And indeed, they saw much better engagement in treatment among those who were started on buprenorphine compared to those who were referred or had a brief intervention. And were much more likely to be using opioids at follow-up compared to those who were referred for treatment or just got the intervention. So this is promising, and we're following up with a multi-site trial. Is it something that the Yale Emergency Department can do and nobody else, or can it be implemented elsewhere? It certainly looks like it could be implemented elsewhere when there's a significant issue on opioids. Now let's focus a minute on some newer trends in the data. We are seeing an increase in the number of buprenorphine prescriptions, so increased access to treatment, at least by this measure. We saw an interesting drop in hydrocodone prescriptions. The FDA rescheduled hydrocodone from Schedule 3 to Schedule 2, and there was about a 20% drop in hydrocodone prescriptions. Interestingly, there was not a corresponding increase in the other opioids. So there was an overall reduction. It's not quite as dramatic, so there was some switching from hydrocodone to other types of opioids, but overall, a significant decline. And according to the paper by Chris Jones and colleagues, this represents about 750 million, that's billion with a B, fewer opioid tablets dispensed following that rescheduling to Schedule 2. We have seen a decline in the number of individuals reporting their first use of non-medical opioids. So while this number used to be more new users of prescription opioids than marijuana users in the early 2000s, it's down about 30% from a peak of 2.5 million to around 1.5 million. That's still 1.5 million individuals first using opioids in any year, but that does represent an improvement. We've seen a marked increase in the retail prescriptions for naloxone. Now, most naloxone is being distributed through community-based distribution and first responder access, but direct-to-consumer and direct-to-family prescription may represent a new route of access, and we are seeing increase in prescriptions. In Florida, there were a set of pain clinic regulations that appeared to drive reductions in overdoses, particularly a marked reduction in oxycodone, Xanax, and methadone deaths, and without a corresponding increase, so no suggestion that there was a real shift to heroin, at least in Florida, during the period from 2010 to 2012. Now, I would point out that this is the same time as oxycodone reformulation kit was put into place, so it may be a multiplicity of actions to produce these reductions in overdose deaths in Florida. Okay, I'm catching my breath, and I'll give you a chance to catch yours. I've highlighted for you the complex relationship of the prescription opioids with heroin, that it's driven by an overall high rate of prescription opioid availability, producing a proportion of individuals that begin to use these opioids non-medically, a small percentage of whom go on to use heroin, but a modest or small percentage of a large number, still a lot of heroin users. We also see market forces or supply side issues being part of this issue, and the relationship is complicated. For instance, I'll say right now, CDC has a funding announcement that will be reviewed at the end of April to help fund some additional research to look at the relationship of the prescription opioid policies and practices and their relationship to the heroin epidemic. So while we think we have some information about it, we need to be collecting more to really unravel this and figure out where can we best intervene from a prevention and treatment standpoint. And with that, I want to thank you for your attention. I think I can open up for questions now. I'm not quite sure how this will work, but I'll ask Erin to open it up now for questions.
Okay, so there were a few questions that came in, Dr. Compton. There was one viewer who asked, how does the physical dependence of pharmaceutical opioids compare to the physical dependence of heroin? You stated both are treated basically the same by the brain, and often a user can't tell the difference between street and farm opioids.
There can be, of course, there are some differences. The duration of action may differ. For instance, fentanyl has a very short duration of action, so injection may need to be even more frequent if it's a fentanyl-based drug than heroin. Some of the prescription type opioids have a long action, but for instance, that oxymorphone that was part of that outbreak in Indiana has a very short half-life. So those people in that setting were typically injecting 3 or 4 times a day, compared to most typical heroin injectors that even in a full-blown situation will use 2 to 3 times a day. So there are subtle differences, but once it gets into the central nervous system, the brain does not distinguish well among the different opioids.
All right, thank you. Then there was another viewer who wanted to know if there were any head-to-head studies of Vivitrol versus buprenorphine or naloxone.
There's one going on right now that our Center for Clinical Trials Network at NIDA, so our multi-site trials network, is doing. It's been difficult to imagine how you can do a head-to-head trial of buprenorphine and Vivitrol. I struggled with this because there's no way you can maintain blinding. One is an antagonist and one is an agonist. So they have markedly different effects even when taken as directed. Also, an individual signing up for this study may or may not want one or the other one. So you need to balance some equipoise in terms of the research design. Was a complex set of questions. So we'll certainly be very excited to see how they work in real world settings and compare. I think some of it will depend on patient desirability. As a clinician, I'm always glad to have multiple options to increase the range of interventions I can offer my patients.
All right, another viewer was looking at one of your charts and noticed that it said that buprenorphine should be given 3 to 4 times a week, but he had always seen it dosed daily. So he was wondering if you could explain that.
It's typically dosed daily, and I'm not sure which chart said that. And I'll have to take a look to make sure I don't have something incorrect, or I'm not You have an eagle eye. I don't know where that was.
Okay. One more question.
Oh, no, I see. It can be, it does have a long enough half-life that it can be delivered as infrequently as that. I mean, typically methadone is dosed daily, but methadone can even begin to wear off towards the end of the day. So if you're taking methadone for pain, for example, it'll typically be prescribed twice a day.
Okay. Another viewer asked if there is any data on overdose deaths post-Vivitrol treatment.
There's certainly a risk for overdose when treatment is stopped under any circumstances. So when people drop out of substitution treatment, when people drop out of non-medication treatment, there's a risk for overdose. And there is a risk when people drop out or are no longer participating in Vivitrol.
Okay, and one of our other viewers wanted to know, why does Suboxone contain naloxone if it is metabolized by the liver?
Well, the advantage of Suboxone including naloxone is that if it is dissolved and injected, the naloxone will have a full effect. So the idea is that you reduce the propensity to abuse, to misuse the buprenorphine when it's combined with naloxone. So that if it's taken as directed, under the tongue, allowed to dissolve, so it's essentially by mouth, that the naloxone is ineffective and does not produce withdrawal. But if it is dissolved and injected, it will put somebody into withdrawal. That's the reason for adding naloxone to it.
Okay, thank you. And one of our NDEWS Sentinel Community Epidemiologists was asking if your slides can be available for community presentations, and we are expecting to be able to post your slides on the NDEWS website. So
you're welcome to post them as a PowerPoint or PDF file, whatever makes it easy to use. You're welcome to any of these.
Okay, thank you
None
very
of
much.
these are pre-publication. Occasionally I'll use slides that are like a week or two before somebody publishes something, but I don't think I have any pre-publication data in here. I don't, so you're welcome.
Okay.
Why don't, I at least see lots of other Q&A on my little indicator.
Yes, there are.
Why don't we save some of this for the discussion between me and Dan at the end? And why don't we turn it over to Dan now?
All right, good idea. Are you ready to go, Dan?
I am.
All right.
All right. Hi, everyone. Dan Ciccarone here. I'm at the University of California in San Francisco in the Family and Community Medicine Department. I'd like to present you today a talk on a more dangerous heroin, emerging patterns in the heroin overdose epidemic. Thank you so much for joining today. Thank you to Dr. Compton for a very insightful and evidence-based talk, and for Aaron and the whole NDEWS team for organizing this. So my objectives briefly, I want to sort of compare and contrast the prescription opioid and the heroin-related overdose epidemics. Moving forward, you're going to hear when I say opioid, I'm going to mean prescription opioid, and when I say heroin, I mean heroin. And this comparison is going to look at some demographic differences and some regional differences in these two overdose epidemics. I'm also going to look at changes in heroin supply in a little bit more nuanced detail than Dr. Compton's presentation, and examine the evidence for contamination or adulteration of the heroin. And then I'm going to move on to a qualitative bit, looking at stories, relating stories of heroin adulteration, particularly focusing on a case study of Baltimore. The data in this section is quite preliminary, and I'll remind you of that when we get to it. This is part of the Heroin in Transition study. Of course, I'd like to thank NIDA, Dr. Compton, my project officer, Moira O'Brien, for funding this and for shepherding it. It's a multi-methodological study. I'm only going to show you a sliver of what we have aimed to do. It has both quantitative and qualitative aims. Our overarching goal is to look at new heroin source forms and how they are perceived and used. In order to do that, we're also going to examine the emerging patterns in the consequences of these use of new novel heroines. And in order to understand both of these, we need to understand how the heroin supply flows are changing. The data I'm going to analyze in the quantitative bit comes from the Nationwide Inpatient Service, the NIS. I'm not going to spend a lot of time on this slide. I will suggest that you see any of my papers or Dr. Jay Unick from the University of Maryland, who's the lead on this part of the study, to see how we use this stratified sample of hospitalizations in our analyses. The years that we're looking at are 1993 to 2013, the latest year that's available. On the qualitative side, part of the heroin transition study has a rapid assessment or RAP project. It's a hotspot study with ethnographic and qualitative methodologies. We are in 3 to 4 cities per year. We are going as of this point. We have preliminary findings from Baltimore and San Francisco. I present Baltimore. Sarah Mars at UCSF is the lead on this. In order to understand supply, I use data from the DEA. We put in a Freedom of Information Act request to get STRIDE data, heroin signature program data, domestic monitoring program data. Our last FOIA has been rejected twice. We're about 9 months in the wait here. So if there's anyone from the DEA on this call who wants to help, please get in touch with us. We also use NFLS, the National Forensics Lab data as well. So my first data slide. This is opioid, again, prescription opioid overdose hospitalizations, 1993 to 2013. We're hoping there's some good news in this, that the apogee has been reached and this decline remains. Unfortunately, heroin use and consequences are also up, and this rise is concurrent with the later stages of the opioid misuse epidemic. Here we have the heroin overdose admissions with an impressive rise beginning 2005, 2007, but certainly a doubling since that nadir. But are these the same epidemics? My team has published a couple of papers, one on the intertwined epidemics, the statistical relationship between opioid overdose and heroin overdose and hospitalizations. This was led by Jay Unick. And also stories of initiation. Sarah Mars has written a paper, Every Never I've Ever Said Came True, about transitions from opioid pills to heroin. But this is only one of the stories that I think is going on. And the questions that we're looking at now is, how does the heroin epidemic differ from the earlier opioid misuse epidemic? And I'm going to go through some comparisons of some demographic comparisons to show some differences here. For example, if we look at age, heroin overdose, these are again hospitalizations. The fastest swimmers are the 20 to 34-year-old groups. For opioid overdoses, it's 45 to 59-year-olds. It's really 50 to 59-year-olds, an over a middle-aged and getting older population, whereas that 20 to 34-year-old demographic curve is in the middle there. This slide just reminds us that when we talk about these overdose epidemics, we're talking about heroin-related overdose. There could be a number of products involved. The syringe here symbolizes the injection product, perhaps heroin. The clonazepam diverted pill bottle there emphasizes that benzos and other sedatives make heroin overdose more likely and with a worse outcome. It's also a reminder for me to tell you all that there'll be a number of graphic photos coming up. I am an ethnographer after all, and photos, as they say, save 1,000 words. Back to the numbers though, looking at age cohorts, we see that in certain cohorts, the dotted top line tends to be prescription, not tends, but is prescription overdose. Opioid overdose hospitalizations, the lower curving up bars are heroin overdose. There's some key convergences in certain demographic groups. Again, that 20 to 24, 25 to 29, 30 to 34. We start seeing this clamshell effect, whereas prescription overdoses are declining, hospitalizations for those are declining, heroin overdose is rising to meet it. If we look at ethnicity, comparing these two, heroin overdose tends to be in the white and African American groups. Opiate overdose is white and Native American, with some curved down decline there. So when we think about these sort of disparities, there's some age disparities. I didn't show you gender slides, but there's gender disparities. Opioid overdose, predominantly female. Heroin overdose, predominantly male. One has to remember that the opioid at-risk population is very large. Dr. Compton reminded us the volume of prescriptions that are being prescribed, pills that are being prescribed, the much larger size. It's a 15x larger size population at risk. So it's easy to imagine a smaller population that could look any way it wants. It could look more of this gender or more of that age, spinning out just because there's a selection of a smaller risk population. But this data here cannot be explained away by a riskier subpopulation. Okay, this is going to look at geographic region now. Opioid overdoses, hospitalizations for them, have been relatively even across the country. You could argue that that top line, the South, is a little bit higher than it's in the other regions. We could point out that there's some good news that second line there is the Western region, and the decline there is impressive. Somebody needs to study that. Why are opioid overdoses going down more dramatically in the West than somewhere else? This has not been presented anywhere else as far as I know. Heroin overdose. Northeast and Midwest. The Northeast, that's that top bar, the top line there, kind of endemic, and we kind of know that. Those of us who have been in opiate field for a while now, yes, the Northeast has had heroin for 50, 60 years now. But the Midwest, that's that second line there. Now, arrow at the bottom there is 2006, just to remind us that this is kind of where the national data shows us an uptick in heroin overdose. whether it's hospitalizations or deaths. Some people say 2007. Okay, the Midwest precedes that by almost a decade, that climb up. And we can see that the other regions are not increasing as of 2006. They're waiting until 2009, 2011 to go up. So something fascinating and disturbing has happened in the Midwest in regards to heroin. So just to sum up this section, if we look at the timing of the opioid and heroin curves, it doesn't really tell us much about transitions. You can tell a number of different stories. But there are some key convergences by ethnicity. That's white ethnicity. There's a symmetrical converging curves in that 20 to 34-year-old age group. Shows some evidence of a switch. And this is what I'm calling sort of the opioid push hypothesis, that highly dependent population. This has been pointed out already, there's literature, there's evidence in the literature now supporting this transition from highly dependent states of opioid use to heroin, which is becoming more ubiquitous, plentiful, cheaper, reliable supply. And so this push hypothesis is that people are transitioning in the ways that we're currently starting to understand. But any demographic difference that we see can be explained by this riskier subpopulation kind of spinning out of the hole. The exception, though, is the Midwest. All right, we have to explain the Midwest using a different hypothesis. This slide is from inner city Baltimore. It just reminds me that when we talk about statistics, we lose track of the fact that each death is a person, and each person is missed by their family and by their community. This is Theodore Cicero and team's slide again. I'll just restate what Dr. Compton stated, and that is that in successive cohorts of people entering heroin treatment, those in the 2000s have predominantly started their opiate career, dependency career, with a prescription opioid, and then wound up in treatment with heroin. That's about 75% of them started with pills. But I want to point out that there's an increase in heroin dependent folks initiating with heroin. And I suspect that if we had data going past 2010 to current, that this line continues upward. Now I'm going to move into the heroin pull part of the sort of metaphor or hypothesis here, that heroin itself, its supply, its distribution, the way in which it's being formulated now, the actual composition of the product that people are calling heroin. And if you remember my title, heroin was in quotes. That there's something that's pulling people towards it that has nothing to do or has less to do with the opioid to heroin transition phenomenon. Here we see a doubling of the U.S. heroin seizures. Here we see a dramatic rise in poppy cultivation in Mexico. We could also look at opium production. It's way up in Mexico. And heroin seizures at the southwest border, as being the predominant way in which Mexican heroin is smuggled into the United States, those seizures are fourfold. Heroin comes in different source forms, what I call source forms, and that is the product that comes from different regions of the world acts different chemically, is used differently, and produces different medical consequences. This is a theory that I've been pursuing for a dozen years now. We'll start with white powdered heroin down at the bottom left there from Southeast Asia. We don't see this in the United States anymore. Reports of white heroin need to be investigated, and that's what we did by going to Baltimore. Brown heroin tends to be from Colombia, Colombian-sourced heroin. Some people will call it white, but at best it's a creamy white. It's a off-white or a light tan. Most likely it's, as you see here, which is tan, maybe a light tan. And then there's Mexican black tar heroin. I'll remind you, these are all sort of stereotypes of what heroin used to be. All of this is exploding right now. But Mexican heroin typically, stereotypically for 20 years was this chunky black or brown solid. It's fussy, it's difficult to put into solution. Users hate it, except if they're romanticizing about it in a part of the country that doesn't have it. Why is heroin source form important? This gentleman is injecting black tar heroin, and the photo reminds us that black tar heroin has been consistently associated with soft tissue infections, mostly in small studies. Our team, I've just gotten an acceptance. DAD is going to publish a paper that we wrote looking at a national study about how black tar heroin is a risk factor for soft tissue infections. I love this slide from the DEA. It's one of my favorite slides. I love when it comes out every year. Unfortunately, it's only up to 2012 here. This shows us the DEA's understanding through the heroin signature program where the different heroins that hit the country come from. It's a lot of data. I'll walk you through it. The blue and yellow are Southwest Asian and Southeast Asian heroin. And we can see through the 1990s a dramatic decline in the proportion of heroin samples that the DEA is sampling that come from those source regions. And they determine source region through this chemical analysis, hence the heroin signature. Heroin sourced from Colombia. Here it says South America, but we understand it as Colombian. In red bars has taken over, and it didn't take over the United States heroin market through warfare or through gunfights. It took it over through a better product, a product in a highly low. If you want more, I have a number of papers on this and references in those papers can be looked up. My computer's telling me there was some internet instability. Folks can hear me. So just to repeat, the Colombian heroin came in, took over a large part of the U.S. heroin market. Okay. I don't know what to do about that, except to go slower and cross my fingers. How do I sound now?
Okay now. You sound good now.
Okay. So please feel free to interrupt if that happens again. I'll just slow down and maybe repeat the slide. So the circle here is surrounding the South American, or as we understand it, Colombian heroin, and its dominance in the U.S. heroin market is best understood by the DEA. But there's also a rise in those green bars, Mexican-sourced heroin, over the last decade. Now here's the problem. There's also a rise in heroin of unknown source, meaning the DEA and their laboratory are not sure what the chemical signature is and what country to attribute its source from. If we look at the chart on the left there, those red bars point out that in the East Coast, Colombian heroin predominates. And we've understood this for ever since Colombian heroin came in, almost 20 years now, that it predominates in the East Coast. But there's now up to 25% of the heroin supply that is of unknown source. If we look at the right graph, this is St. Louis. St. Louis being in the middle of the country has always been a dividing line, but it has tended to be a Mexican-sourced heroin city, just like all the cities west of the Mississippi River. But this is changing. We see now more red bars of Colombian heroin, but also a dramatic increase in heroin as of unknown source. So, what's the evidence for a more dangerous heroin? Let's talk about fentanyl-laced heroin. Let's talk about the possibility of novel Mexican heroin hitting the U.S. market, other synthetic opioids, and then move into our case study of Baltimore. Fentanyl-laced heroin comes, we have increasing understanding that this is a common contaminant in the heroin supply. So there is fentanyl-laced heroin, and there's heroin-laced fentanyl, and there's just plain fentanyl out there. And of course, we also need to consider and keep track of the fentanyl analogs. NFLS reports that fentanyl has increased 300% in their database, criminal justice samples from late 2013 to early 2014. This is clandestine produced fentanyl, not diverted pharmaceutical, not scraped fentanyl patches. It is stronger than heroin by weight. The DEA and the CDC were concerned enough to produce warnings in 2015. The DEA will tell us that the sources are Mexican predominantly, I also am suspicious, highly suspicious of China when I think about sort of large quantities of novel psychoactive substances or synthetic cannabinoids or just illicit pharmaceuticals. I'm thinking, well, can Mexico produce enough of this fentanyl, or is it ultimately coming from China? There is evidence for the fentanyl analogs coming from China. And this is analogous to what happened with cocaine. In fact, what's currently happening with cocaine, with a large proportion of samples having levomistol in it. And I'll remind the group now that we're talking about adulterants, right? The adulterants are chemicals that are added to the primary drug, cocaine or heroin, as it may be, to produce an additional effect, perhaps even a positive effect. If I wanted to make heroin a better drug, we will see this adulterant from time to time. I would put diphenhydramine in it, or another powerful antihistamine to reduce the itch from it. And this is as opposed to dilutants, which are just fillers that are used to bulk up the product for market, make it more appealing. So the idea that there's more adulterants and more powerful adulterants in the heroin market is the thread that we want to follow. Here's NFLS data showing that there's been a rise in this fentanyl, a dramatic rise specifically, especially in the Northeast and Midwest regions. But that these rises are relatively late or recent compared to the curves we saw earlier, particularly that Midwest curve of a rise in heroin overdose. We think about the Mexican heroin market, it is changing dramatically. Opium production is up while Colombian production is down. In addition to fentanyl, some of the things we should consider, we're moving to a little bit of speculation here, that the rising heroin overdose in the Midwest may be due to a more purified product coming from Mexico. There's that rise in heroin with unknown DEA signature. Perhaps it's a Colombian mimic. Areas are seeing Colombian heroin that haven't had Colombian heroin before. Is it possible that the Mexican DTOs, with a technology transfer, are producing Colombian-like heroin? They've been working with the Colombian DTOs for several decades now in terms of sharing routes, distributing cocaine, for example. Is it possible that there's been a technology transfer? The DEA does report that there's been some evidence for Mexican white heroin. And we're going to explore that a little further in a second. Now, looking at heroin overdose in New England, there's been as we all know, there's been a series of reports, particularly in the New York Times, about what's going on in New England, quite disturbing heroin hitting the smallest towns and rural areas. There's a new distribution model. Again, this is all in addition to the possibility that fentanyl is ubiquitously contaminating the heroin in the Midwest and the Northeast and the Mid-Atlantic states. But in addition to this, there's distribution innovations where heroin is being marketed by entrepreneurs in a way that gets it into smaller venues than the large classic 1970s inner cities. It's going to small cities. Think Gary, think Madison, think Cleveland. If you want to read more about this, I highly recommend Sam Quinones's book, Dreamland, which came out last year. And then there's the synthetics. There's reports of fentanyl analogs. This is just a short list of them, and also novel synthetics. And I think NDEWS privileged to be on their listserv. I implore you all to be part of it so you can get these alerts as well. Let's move on to Baltimore. Baltimore has a large injection drug using population. 19,000 is the latest estimate that I got from the city data. There's been a doubling of heroin overdose deaths, 2010 to 2014. A dramatic rise in fentanyl that lines up with the national data starting in late 2013. In our ethnographic work there, again, this is brief immersion ethnographic work. We've been there twice now. The heroin scene is old school. Okay, it's an open street scene, dealing on the corners, dealing out of abandoned buildings. It's a branded heroin, not necessarily on the packaging, but people will go and seek a Mike Tyson or a certain brand that's being hawked on the street. There are free samples that are given out, tastes, so that people can try the new brand that's there and develop a little bit of brand loyalty. The brand loyalty doesn't last very long, it lasts a couple of days, but brand loyalty nevertheless. There's two types of heroin there. There's a raw version and a scramble version. Everyone in the using scene understands this distinction. It makes for a very good natural laboratory for me and my team. It's a city on the mend, improving economically with an slowly increasing population after years of decline. But it still has an impressively decayed infrastructure. There's numerous neighborhoods with abandoned buildings, deserted streets, and alleyways, and these make for convenient venues for drug injection. We actually explored one of these de facto shooting galleries in an abandoned building. They're quite disturbing, a lot of detritus, as you can imagine. There's drug paraphernalia on the floor, and this is where folks come to inject, sometimes alone or in pairs, often in pairs, sometimes in large groups, sometimes following each other. So this is what I mean by sort of de facto shooting gallery. There's all the risks inherent in a dyshygienic social injection setting. People try to be safe. Here we see sterile syringes. We see a brand new blue tourniquet. We see alcohol wipes to clean the skin. Unfortunately, there's also areas to be concerned. Who knows where this water came from? Lots of dyshygienic condition as well. Again, I'll remind everyone that this work is very preliminary. Our last field work, we've been there twice. Our last field work was just a few weeks ago. But we're starting to get a good understanding of what's going on there through about 28 interviews. The heroin is considered of high quality. One person coming from Ohio who moved to Baltimore for the heroin product says, the best stuff I've ever used is the stuff I'm using now. For an ethnographer, anyone who's worked one-on-one with heroin-using folks, this is a statement you never hear. People always say the stuff I used last week, the year before, 10 years ago when I first started, that was the best stuff. They've romanticized the past. You very rarely hear the best stuff is now, and this is not the only person I heard it from. But also to contradict that, there's the 60-year-old who's been using for 30 years who's not so happy with the current product. And when asking him the question, how does the heroin you're using now feel? It's kind of like heroin. It gets me well, but it also tastes chemically. And by chemically, they talk about not only the feeling in their body, but literally a taste. Sometimes they get the taste in their mouth or a smell in their nose. And that's not typical for heroin, for diacetylmorphine. That shows evidence of contamination. Fentanyl contamination is likely in the synthesis in my head, from what I've heard. There are other synthetics that are possible. It's actually possible that fentanyl contamination is not only likely, but that it's ubiquitously contaminating the heroin in places like Baltimore. It's sometimes sold as is, as fentanyl. Sometimes it's desired. Not often, though, because folks know that it's very short-lasting. And they can feel that part of it in their body. They can feel it short-lasting. They can feel it wear off. The users know this. There is also fear and concern. We've had some old-timers report to us that they're doing tester shots, that they're concerned enough about the heroin that they want to do a little taste of it, a little test of it before they inject their full dose. This is unusual. It's a good harm reduction public health stance, but culturally it's not always adopted. Here there's enough fear that it's being adopted, this good common sense approach. This is a product I'm concerned about. This is a product called Scramble. It's a white heroin. And as I mentioned already, white heroin is unusual. It's fluffy, it's powdery, it's not off-white. This is salt white, this is snow white. It's a white heroin. Baltimore's unique. We don't see heroin in many places being sold in capsules. This white powder heroin, it's the first time I've ever seen it. It's being mixed locally. People report that there's multiple powders being put into it. Okay, not just the presumed evil fentanyl, but there's a suspicion of benzodiazepines being routinely mixed in. And it leads to a mixing problem. If you have a very powerful opiate like fentanyl, and you're mixing in with a powerful but not so opiate like heroin, how do you ensure adequate mixing? When you're the dealer, and it's being mixed locally too, so you have these small to medium batches with dealers that are kind of young and a little bit inexperienced. How do they adequately mix it so that one person doesn't get a larger dose of fentanyl? People describe the contrast to raw heroin. Raw heroin is a more dependable product. It is a more powerful heroin. And yet people are choosing scramble because it has a better rush. These kinds of distinctions are unusual. People like powerful heroin. They often go for quality. But here's a nuance and connoisseurship where people are arguing for a product based on its first few minutes of effect, which is the rush. Why scramble is dangerous is that it's highly variable. There's a wide range of prices out there. There's a wide range of volumes. Those capsules are quite large for the $10 or $20 that people are paying for them. There's a lot of volume in them. The color changes a lot. Maybe that means nothing. Maybe that means everything. But it could be sparkly. It could have colored speckles in it. It could have blue and red and all sorts of things. Here's what concerns me even more, that heroin typically, when cooked up, is iced tea color. Well, black tar heroin is very dark, but Colombian heroin, heroin that you're going to see in Philadelphia, New York, and Newark, is when it goes into solution is a classic golden brown. There was even a song out of London years ago that talked about golden brown. It's iced tea colored. Okay, what I saw when heroin was prepared and injected was clear. I don't know of heroin that's clear. The effect, people like the good rush again, and the duration of effect can be quite broad. Anything from half an hour, well, that, if it's short acting, we start to think that it's fentanyl-y, but also 12 hours. People report there's this heroin that they like that lasts a long time. And one has to wonder what's extending the heroin to make it last that long. And it's predictable on a daily, weekly basis. Very unpredictable, which leads to overdose potential just based on the variation in quality. And it's growing in popularity and market share. Here we see that clear heroin solution. I would have thought this was cocaine or some other drug, not heroin. And I'll leave the Baltimore section with this slide. It's hard to disagree with the sad but profound message. So I'm going to wrap up now, give you my final thoughts. Heroin is an evolution. I've been studying heroin for a number of decades now. And when Colombian heroin entered the U.S. market, it increased heroin overdose rates. It caused a mini epidemic of heroin use and heroin death in the 1990s. And so the novel entry of a new form of heroin can cause these waves. And so is the current epidemic partly or substantially due to new forms of heroin coming into the country, particularly Mexican sourced? Is there widespread fentanyl and other fentanyl-like, not fentanyl-like, but other synthetic adulteration? There are on top of, intertwined with.
Dan, you cut out again. Maybe you could repeat a couple sentences for us.
So I'm pausing. How do I sound now?
You sound fine now.
Okay, thank you. Sorry for that, everyone. So we've seen this before with Colombian-sourced heroin coming into the country and taking over the eastern part of the country. And the new increases now imply that there may be a new form of heroin, perhaps Mexican-sourced, that there may be widespread fentanyl or other synthetic adulteration. There's good evidence for fentanyl, not for necessarily for the other synthetics. That there's wider distribution models that are getting heroin into smaller hamlets and places where it puts naive, if you will, populations at greater risk for initiation and dependency. And this is all on top of, intertwined with, interconnected with an opioid pill misuse epidemic. So in conclusion, I think there's multiple pathways that are going on here. There are opioid to heroin transitions that like the dominant story that's beginning to be built in the literature now that are based on a high dependency opioid user finding their way to heroin based on greater availability. The question does come up about whether some of these transitions are being forced by opioid restrictions. Say the industrial worker hurt, became dependent on pain pills, but still has legitimate pain, who is being cut off. And we have heard about pill refugees, opiate pill refugees in various parts of the countries. And this has a question mark next to it because it needs to be studied. There's also evidence that heroin is becoming the initial drug of choice, that because of its expanded supply and the new market strategies in New England, Mid-Atlantic, and Midwest, that it's becoming, that heroin has a drawing pull force of its own. But there are products that we don't understand, and we need to get a handle on them. Fentanyl, yes, but it can't explain everything because, at least based on the NFLS data, its dominance or its rise is a relatively recent phenomenon. And it doesn't explain what happened in 2012 in terms of the large amount of heroin overdose we saw, unless there's a testing bias in here. And I'd love to hear from the National Forensic Lab folks about what testing was like in 2009 to 2012. Final thoughts on the methodological challenges. We need to be careful, as Dr. Compton suggested to us, that there may be some misclassification, just looking at of fentanyl. So just looking at our deaths, our data. This is using the NFLS data. We just ran this data yesterday. If we compare hospitalizations, we see that distinct curve downward. That's the graph on the left there. If we look at deaths, and these are deaths within the hospital, not necessarily, and they're obviously reported to the national systems, but not national deaths, but in the NIS stratified sample, there's that uptick. Now, is that uptick 2012 to 2013 due to misclassification of fentanyl as opioid when it should be fentanyl as heroin? And that the hospitalization deaths, the hospitalizations are being coded by doctors and other billing people, that the stigmata of injection drug use predominated and they were coded properly as heroin deaths and not as opioid pill deaths. Last couple of slides, some challenges that are in front of us. We need better surveillance. We need a public health forensics. If this was a foodborne outbreak, we would not only examine the ill patients and the people who have died in terms of what hurt them, doing medical testing, finding out what infection they had or what poisoned them, but we'd also find out what the source of that poison or that infection was. We'd look at the lettuce. We'd test it for bacterial contamination or chemical contamination. We need to do the same thing here. Yes, the National Forensics Lab and all the small labs that feed into it are looking at criminal justice obtained products. But if public health were to do surveillance, we might ask slightly different questions. We might do our testing or our sampling in a somewhat different way. And this needs to happen. This is a priority. Synthetics are the new reality. We know from novel psychoactive substances and synthetic cannabinoids that these are becoming ubiquitous and common. Why wouldn't synthetic opioids also become ubiquitous and common in this new age? We need to understand basic epidemiology, basic ethnography. What are the use patterns? What are the consumption patterns? And what are the consequences? I'd be remiss if I didn't talk about harm reduction. I've been a dedicated harm reductionist for 2 decades now. Introduced naloxone in peer use over 2 decades ago. And I'm glad to see that it's no longer an underground movement or just a peer level movement, and that it's above ground, it's legitimized, and that there's widespread policy and technological innovations that are expanding its use. We need this expansion, and we need it now. We also need to expand medical assisted treatment. As Dr. Compton brought out, we have few of the DEA registered physicians are buprenorphine approved prescribers. We need to expand this. We are going to have a workforce shortage in treating the opioid and heroin epidemics. Buprenorphine is, because it can be used by primary care, is one way to address this workforce addiction medicine shortage. Okay, now I'm going to bring up a challenging topic. I understand this will be controversial for some of the audience, but the conversation has begun again around supervised injection facilities. This is a growing intervention worldwide. The best evidence comes from the Insight facility in Vancouver. There are numerous impressive publications have pointed to a decrease in overdose, a decrease in hospitalization, a decrease in viral and bacterial infections, and the like, and also an increased uptake of medical and substance use treatment. Supervised injection facilities, people call them SIFs, have in Europe and certainly in Vancouver, have stemmed out of crises. In Vancouver, it was the HIV crisis of the 1990s. We have a crisis now. This is an idea that still has life, and it needs to be explored scientifically and compassionately. That doesn't mean that we don't have challenges with it, right? In conversation with Dr. Compton, he reminded me that we need to have a fully functional system where there's wraparound services that folks who use a safe and supervised injection facility can also seek, when they're ready, drug treatment or get medical services for their abscess or other needs. And that Canada and the U.S. are not like the U.S. Canada and Europe are not like the U.S. That stigma may bedevil us, right? People who we plop down a SIF somewhere, people at risk may not want to use it. It might be stigmatized. Oh, I'm not going to go into that place. I'll be outed as a user. Communities may not allow it. NIMBY effects, of course, and the culture at large may not be ready. And that's not to mention those pesky little things like legal and political issues that need to be overcome with this. This is Insight. It's a dated photo. It is a lovely facility with a clean injection place for people to inject with medical staff ready to help. I'll end with this cartoon. This dates back to 2002. It's by Aaron McGruder in the Boondocks. This is Huey, one of his main characters, who's looking cynically at the television as it talks to him. Following the lead set by McDonald's with their new healthier French fries, the Organization of Worldwide Heroin Manufacturers announced that a new low-calorie version of the popular narcotic would hit the streets by January. A spokesman for the organization said that, like McDonald's, we have learned that just because your product is highly addictive and deadly doesn't mean you have to kill your customers off quickly. Healthier heroin is just good for business. There's something going on in the heroin supply. It needs further investigation. The DTOs and the dealers are not trying to kill people, but they're trying to expand, improve, push a new product where there's an accidental death rate associated to it. It behooves us to get on top of this very soon. Some acknowledgments. Of course, I'd like to thank my team, Jay and Sarah, for leading impressive research and studies and papers. Jeff's our new ethnographer. He joined me in Baltimore. The NIDA funding, of course. Johnny Zibel for late night conversations, extensive ones around what we're going to do. He's from the CDC, what we're going to do about the heroin epidemic nationally. The Baltimore City Health Department, Mishka Turplin, who's been helping me a lot to enter the scene there. And of course, the Needle Exchange staff, Jeffrey Long and Derek Hunt, the supervisors there, NDEWS staff, of course, and Eric Wish, the PI of it. The Maryland Department of Health, Michael Bayer for some of the Maryland data that I presented, Philippe Bergois from my career mentorship. The DEA for impressive data, which I've borrowed liberally from, I thank you. Photo credits go to Fernando for some of the Fernando Castillo for some of the Philly photos. The rest are from me. Fernando took that photo of me coming out of an abandoned building in Philadelphia. And with that, I will thank you all for your kind attention, and we get to move into our full question mode now.
Okay, thank you very much, Dr. Ciccarone. That was a great presentation, and we really appreciate all the information you shared with us this afternoon. And it looks like we have a whole lot of questions, about 37. So we won't get to all of you guys this afternoon, but we will try to get through a few of them. And as I mentioned earlier, we will be posting both of the presentations at www.ndews.org, www.ndews.org. Give us about a week to get everything together and posted, and hopefully you will be able to find what you need there. And in the meantime, we'll try to get to some of the questions here. Not entirely sure the best place to start. I did notice that one of our viewers actually was responding to a question that we brought up earlier, which was asking about overdose trends post-treatment with Vivitrol and things like that. And that viewer mentioned that there was a study about that out of Australia. So the NDEWS Coordinating Center will see if we can track that down and share that with folks. And so let's see. So one of our viewers, Dr. Ciccarone, asked for more information about the difference between raw and scramble heroin in Baltimore. And one of them asked, they noticed that you had showed it in pill form and were wondering how somebody would use that.
Sorry, I heard something in pill form. Is that what you said?
Yes, that was our question.
Yeah. Okay. So the pill, the capsule, is one of those ubiquitous gelatin capsules. People are buying them and just filling them with powder. The gelatin capsule is discarded. The powder is dumped into that cooker. So you saw the powder in that aluminum cup. That's the cooker. The gelatin capsule is not consumed. The difference is raw heroin is a gray to brown heroin. It kind of reminds me of Philadelphia heroin. I suspect that it's Colombian-sourced light brown powdered heroin, although I'm not quite sure. It does cook up to the classic iced tea color. It's a very powerful heroin, and it is a paradox when people choose not to use that, because the number of neighborhoods that are selling raw heroin are decreasing over time. At least that's my impression based on my questions that I've been answering. And scrambled heroin is winning the day, mostly because of that early first few minutes rush. And there's then a disregard about what happens next. They want it to have legs. They want it to last several hours. But in pursuit of their rush, they're willing to forego some degree of long-term quality. That's unusual. That's a qualitative finding that requires further exploration. Thanks for the question.
All right, thank you. And another one of our viewers asked how much of heroin distribution is via internet orders and shipments instead of brick and mortar. I don't know if either of you guys have anything to offer on that.
I have no data on that.
Okay.
Certainly, when you look at the answers to the National Survey on Drug Use and Health, internet is not a typical source even for pills, let alone for, so that's at least an indication that the internet is not a widespread source of illicit drugs. But we have no information about the sort of, the black part of the internet where some of this might take. But
all right, thank you.
So-called darknet.
Right. And there was a report recently out of the European drug monitoring system about that, which might be of interest to some people. And
I think this sort of intersection between the supply side, drug dealing, and the drug markets with drug using behavior and with the public health epidemics is something that we haven't examined as thoroughly. It's hard to study. It's a whole lot easier to do surveys and to interview people. But looking at the markets in combination is tricky. And it's also a different constituency, because it might mean that the police have to be your partners in some of these activities. But I encourage those who are interested to consider research grant applications in that area.
all right, thank you. And another one of our viewers asked, for folks who might be initiating opioid use through heroin, is there any indication of substance use other than RX opioids as a precursor?
The paper last year by Chris Jones and colleagues that was in MMWR in July that summarized sort of current heroin epidemiology reminded us that heroin use is comorbid with all sorts of other behaviors. Prescription drug use disorders, or drug use only just one of them. Alcohol, marijuana, other substances, as well as psychiatric conditions. So I would pay attention to the broad set of risk factors that are related to heroin. It's not just the prescription pills.
Okay, thank you. One of our viewers, Dr. Compton, was following up on your presentation and was asking what you think is an appropriate definition for prescription opioid misuse. And does our definition of misuse include those who use their own opioid prescription for medical purposes but not as prescribed? How much does our definition impact our high rates of reported misuse?
Well, it may help. It's a great question. And I am guilty of using a variety of words and definitions, sometimes not as precisely as I might hope. The term abuse is probably the most obvious, where it both is sort of a generic term for the agency where I work, the National Institute on Drug Abuse, as well as it describes a diagnosis, at least in the former DSM system. When it comes to misuse, you'll notice that I use the term non-medical use of prescription opioids. So it was outside of a doctor's orders and other than as prescribed. It may include use for a so-called medical condition. There's some work by people like Carol Boyd and Sean McCabe that suggests that those early sort of pseudo-medical use, in other words, it's not my prescription, it's somebody else's, but I'm taking it because I'm in pain, do not have the same set of risk factors and background as somebody taking them to go to a party or to get high. So there may be important distinctions depending on the motivation for use. And I mostly encourage you to take a look at how each author defines it, because we're often a little loose in how we use these terms, and we haven't come to an agreement on how to define.
Okay, thank you. And Dr. Ciccarone, one of our viewers picked up on what you were saying about injection sites, and she was asking if you could talk about that a little more to explain where the injection sites fit into things. She seemed to be a little concerned that you were promoting them as a place where addicts can go to use illegal drugs or misuse prescription drugs.
Yeah, so I think the question is around the supervised injection facilities, which do not exist in America. In the US, they exist in a couple locations in Canada and a couple hundred in Europe and Australia. So the way those work is it's a clinic, it's a medically supervised place to inject. People bring in their own drugs, however they've obtained them, whether it's through prescription or on the street. There's a few places in the world where people can get prescribed heroin for injection, but that's the minority. So the safe injection rooms are street drugs, and they're used in a supervised way to help reduce the medical consequences, the consequences that one might imagine when looking at that unsterile, unsupervised, abandoned building shooting gallery kind of situation. The contrast here is stark, that a medically supervised facility can help treat an overdose that happens on site, can help encourage hygienic and safer routes and patterns of injection, and respond to medical problems, can engage people in a way that furthers them along a stage of change. Perhaps they're interested in reducing the dose, their dependency. Perhaps they're interested in treating a comorbid medical or psychiatric problem on their way to considering getting their substance treatment. And I recognize this is a very, very controversial idea. This is not ready for prime time. What I'm agitating for here is to get the conversation going again. And there are a number of cities that are considering this. The mayor of Ithaca, Maryland has some legislation, California, San Francisco, and another undisclosed city in California are working on this issue. But we have state and federal legal hurdles, even if the local populace and community leaders want it. The drugs are illegal. The paraphernalia in many places are illegal, and there's federal statutes that will block this idea at the current time. But we are in crisis, and crisis needs us to think outside the box.
Do you know if there's been any research or if there's any data available on how many people who go to clean injection sites, for instance, in Vancouver, go on to treatment or abstinence?
Yes, I don't know the data off the top of my head, but there are papers from Thomas Kerr and his impressive research group up in Vancouver on transitions to treatment from their facility, the Insight facility.
One of the reasons that that we funded the project in Vancouver, that NIDA supported that project, is because of the availability of so many essential wraparound services. So that the idea of you wanting to go to treatment, well, there's an assumption that treatment's available, which may be true in Canada, but would not necessarily be true in U.S. systems. So there's a lot of pieces to keep in mind if you're considering opening one of these.
Okay, so we'll wrap things up with one final question here from a viewer who asks, in your professional opinions, what do you believe has precipitated the return of heroin when many people, including myself, never thought such a potent drug would ever make a comeback from the 60s and 70s?
Okay, well, I'll start.
Okay.
I think that there has been steady downward pressure on prices. As Dr. Compton showed, heroin is highly pure and at a low price point. So there have been supply downward pressures, and illegal drugs are just like any other commodity. If they're constantly on sale, people will find their way to them. In addition to that, I do think that there has been an opioid to heroin transition. Thirdly, I think that there's new market strategies that are extending it into other populations, and that with greater availability, you're going to find people who are going to either experiment or through social mechanisms, the peer mechanisms, find their way to this dangerous drug. There's also probably a lot of generational forgetting. And that is that, yes, what happened in the 70s is acknowledged by a lot of us, and maybe even people who lived through it. But those folks are not banging the drum saying, don't do as I did, right? They're getting old. And so new generation is going to do what a new generation is going to do. And so we see from the heroin curves that, yes, if you wanted to define an epidemic, show an increase in use of a dangerous drug among 20 to 24-year-olds. There it is. That's the definition of an epidemic. We are currently in a U.S. heroin epidemic, whether we like it or not.
I would want to add that this is, you're, in a way, you're asking us to speculate about why there are increases, and we don't completely understand the full causes of why drug epidemics wax and wane over time. But I think what Dan's mentioning in terms of generational forgetting is probably one of the key factors, that those who remember the difficulties and the problems in a previous generation are not those growing up right now. And each group has to kind of learn them in some ways for themselves. What we can do is perhaps speed that along with extra information and also provide the way to keep people safe in the meantime and alive, so that there is a chance to turn their lives around.
Thank you to the audience.
Yes, thank you, everyone. Once again, we really appreciate you joining us and all the questions and comments that you shared with us. And we will go through them and see what we can pull together to post on the website. And one last time, that's www.ndews.org. And just to let you know, our next webinar will be on April 27th at 2 p.m. And our speaker then will be Dr. Michael Ballman from the Designer Drug Research Unit of the Intramural Research Program at NIDA. And he will be talking about designer drugs of abuse and the science behind the headlines. So he'll be getting into some of the pharmacology to get back to some of the questions and suggestions we got from our first webinar. And before we all go, we would like you guys to answer just 3 simple questions for us and give us your suggestions for what other topics you would be interested in hearing. So I'm going to go ahead and launch the poll, and appreciate it if you just answer the questions for us.
While those are being answered, I want to say I'm scrolling through a lot of the questions and I recognize the names of many of the people. And I'm sorry we didn't get to all of your questions. There's some very thought-provoking ideas in those questions. So I hope that those can, even if we can't answer them during this time allotted, I hope those will be posted because I think they'll provide a lot of fruitful discussion for the NDEWS group.
Yes, I also appreciate this robust conversation that's been generated by this question and answer period. And I will also look through these questions as well.
Here, I was going to try voting, but apparently hosts and panelists aren't allowed to vote their own.
Yeah, we'll have to see what we can do about that for now.
Yeah, it makes sense.
And thanks again, Erin, to you and your staff for hosting this.
Absolutely, and we look forward to hosting the next one, and hopefully all of you guys will be able to join us again. And thank you again, Dr. Compton and Dr. Ciccarone, for your comments and your thought-provoking presentations. I think you really got us thinking about things and what we all need to do to keep our conversation moving forward. And it looks like we're getting close to the end of our poll here, but I still see the number going up, so I don't want to cut anyone off who might want to participate.
Well, thanks very much, Erin, and everybody from the NDEWS group.
Well, thank you, everybody. We appreciate your attention this afternoon, and we'll see you again next time on April the 27th at 2 p.m. Bye.